Okay, so so again, the title of the talk is Complementary and Alternative Therapy in Inflammatory Bowel Disease. And before I go further, I also want to make sure that please feel free to put in any questions in the chat box. If I don't get to it during the talk, I will make sure that we have plenty of time to discuss any questions. So these are my disclosures, and as an outline for the talk, first I'd like to start by defining what complementary, alternative, and integrative medicine is. And then I'm hoping to identify the different types of complementary and alternative therapies. Then we'll review the specific complementary and alternative modalities, and hopefully provide you with a practical approach to complementary and alternative therapy in IBD. So according to the NIH National Center for Complementary and Integrative Health, complementary therapy refers to using non-mainstream practice that is used in conjunction with conventional medicine. So that's in addition to conventional medicine. On the other hand, alternative therapy refers to using non-mainstream practice in place of conventional medicine, as the name implies, alternative. And then finally, integrative therapy is more of combining complementary and conventional therapy approaches in a coordinated way. So this is really applying a holistic approach to the patient. So you approach the patient more of a whole rather than an organ system. So it includes spiritual, it includes social, emotional aspects to therapy. So if we focus on inflammatory bowel disease, there's been multiple studies looking at how often do patients with inflammatory bowel disease use complementary and alternative medicine. And a lot of this data or research is driven from patients' input. And we've learned that up to 21% to 60% of patients with inflammatory bowel disease have used at one point a form of complementary and alternative medicine to help treat their inflammatory bowel disease. And then when we looked at what are the reasons that people reach out to complementary alternative medicine, and these are just a few of what's been reported, and I'm sure there's more. One of the reasons people reach to complementary and alternative medicine is because they would like a more holistic approach to conventional therapy. So they want to add a more, approach that is in addition to their conventional therapy. There's also a perception, and we will talk further about that, that complementary and alternative medicine is less toxic or harmless. And again, we'll talk a little bit more about that perception. There's also another reason that someone can reach out to complementary and alternative medicine is lack of response to conventional therapy, and that can definitely be frustrating. In addition, side effects to conventional therapy, specifically the one that was mostly noted, is long-term corticosteroid use. Other reasons that patients have reached for complementary and alternative medicine approaches is wanting to improve their quality of life, wanting to help with other symptoms such as anxiety and depression. And actually one of the more common reasons is because a family member or a friend who uses complementary and alternative medicine has referred the patient to it. So as with our conventional therapy, this applies to complementary alternative medicine. This applies to any therapy that we use. Whenever we want to use a therapy, we want to put it on a balance. We want to balance effectiveness or efficacy, and we also want to balance safety. And there's two concepts that I really want to emphasize, that natural does not necessarily mean safe. And on the other hand, natural does not necessarily mean ineffective. An example of that is, for example, one of the major medicines that we use now, such as aspirin, is derived from a natural plant. And the other part here about natural not equal safe, if something is marketed as natural, it does not necessarily mean safe. Some naturally occurring compounds, if they are put in a high dose, can be very detrimental or harmful and can lead to things such as kidney injury or liver injury. So for that reason, there's been a couple of concerns regarding complementary and alternative medicine. Number one, all of the complementary and alternative medicine are not regulated by the Food and Drug Administration. That means that they are not subjected to the rigorous studies and trials And a lot of the data that comes from the use of complementary and alternative medicine comes either from limited data or data of poor quality or some anecdotal experiences. And the other concern is with the use of complementary and alternative medicine, it can reduce the likelihood of using more effective conventional therapy. So for the rest of the talk, I want to split it into, number one, looking at dietary and herbal supplements, looking at microbiome-directed therapy or therapy directed at the gut composition of bacteria. And then the last one is looking at mind and body therapies, which would be a nice segue from Dr. Kiefer's great talk. So looking at herbal and dietary supplements, this is a list of things that we're hoping to cover. Now, for the first item, which is vitamins, I will briefly touch on that. So we will not go into a lot of detail on vitamins. With inflammatory bowel disease, you could be at risk for having vitamin deficiencies, such as vitamin D deficiency, vitamin B12, or even low iron. So for these, your physician would typically check those levels and then replace those vitamins with appropriate doses. What we will focus on is more of the other dietary and herbal supplements, such as cannabis, which has garnered a lot of attention recently. Turmeric or curcumin. We're also going to talk about fish oil, wormwood, aloe vera, and low-dose naltrexone. And there's many more that we probably don't have time to go into further detail on. So let's start talking about medical cannabis. So the medical cannabis is derived from a plant, Cannabis sativa, and it contains hundreds of different chemicals known as cannabinoids. And the two that are of great interest to us are THC and CBD. Now, THC is known for its psychotropic effects. On the other hand, CBD is also known for its immune effects. And the reason it's important to separate those two is because when medical cannabis is used, it's important to know what percentage of it contains THC versus CBD. Now, the other thing that I think is important to understand with medical cannabis is where these compounds or chemicals act in the body is important. So these compounds bind or attach to certain receptors. And by the attachment, you get the exertion of the effect. Now, there are two main receptors. They're called CB1 and CB2. And the reason I wanted to go into a little detail because it'll help us understand why certain effects happen. Now, CB1 is a receptor that expressed in the brain, and it's also expressed in the gut nervous system. And THC binds or attaches to the CB1 receptor. So it can have effects on the brain and also gut nervous system. CB2 is expressed only in immune cells and the gut nervous system, and therefore any action on CB2 causes effects on the gut nervous system and immune cells. Now let's look at what are the data or the research that has been done on use of medical cannabis for Crohn's disease and ulcerative colitis. So there have been multiple studies done for Crohn's disease that looked at the use of medical cannabis. Most of these studies come from Israel, and these are the results of the studies. One is there was some improvement in symptoms, but it was not very significant, and there was some improvement in quality of life scores. What I want to emphasize is that there was not improvement in any markers or inflammation. That means it did not change the disease course. Similarly, studies that looked at ulcerative colitis and medical cannabis showed improvement in some symptoms and improvement in quality of life scores. But again, the same concept is that there was no improvement in inflammation or the disease course. So what are some of the risks that have been associated or reported with the use of medical cannabis? Nausea and vomiting, and a specific syndrome called hyperemesis, in what it refers to is continuous nausea and vomiting with heavy use of cannabis. It can also affect memory. There has been cases of acute psychosis, anxiety, and there's been some research on the possibility that it can affect fertility in women. So where do we stand on medical cannabis and inflammatory bowel disease? I'm going to read to you the statement from the Crohn's and Colitis Foundation, which supports policy changes that facilitate the conduct of clinical research and potential development of cannabinoid-specific medications, including further consideration for revising the marijuana status as a federal Schedule I controlled substance. So at this point, really we need to have a lot more research, which is ongoing, and hopefully we'll have more results in the future to tell us how cannabis can affect the disease activity. So moving on to turmeric. So turmeric is derived from another plant called Curcuma longa, and it's part of the ginger family. And the active compound of turmeric is curcumin, so you might hear those two interchanged. Now, this is a very popular spice in Asia, and it's been known to have some anti-inflammatory effects. So it's been studied specifically in ulcerative colitis. So there have been a couple of randomized controlled trials. So these are trials where they give patients a curcumin and the other group placebo or the sugar pill. Now, it's been shown that in ulcerative colitis that is mild to moderate, in patients who are already taking medicines such as mesalamine or sulfasalazine, curcumin at doses of 2 to 3 grams per day showed some benefit in putting patients into remission and maintaining remission. And that's both clinical and also on what we see on endoscopy, or what's called kind of like the disease active inflammation part. So far, we don't have any results of Crohn's disease showing positive use of curcumin in Crohn's disease. This was mainly in ulcerative colitis. Now, what are some risks or side effects that have been reported with turmeric? Bloating and nausea were the most common risks or side effects. But another important one that I want to make sure you're aware of is there have been some reports with interaction with other medications, and specifically blood thinners that could increase the risk of bleeding. So it's always important to talk to your doctor if curcumin would be something that you can add to your regimen. So where we stand on turmeric is that in mild to moderate ulcerative colitis, the addition to mesalamine and sulfasalazine, turmeric or curcumin can potentially be helpful. Now, what about fish oil? So fish oil is, we think of it as mainly 3 components: omega-3 polyunsaturated fatty acids, EPA, and DHA. Now, these are found in natural foods, obviously fish, and the other foods such as nuts and seeds. Now, the fish oil has been used to maintain heart health, lower the cholesterol, and there was interest to see if fish oil can help improve inflammation with these properties. So fish oil has actually been extensively studied in both Crohn's disease and ulcerative colitis, and these were relatively high quality studies. These are randomized controlled trials where they gave patients fish oil versus placebo. And in Crohn's disease, unfortunately, it didn't seem like it was very helpful. We didn't notice any added benefit. In ulcerative colitis, there were 6 big trials that were done on this, and the results were fairly poor or mixed. The major risk of fish oil is the fishy odor, and that can be overcome with different formulations. So where we stand on fish oil is that the data on the use of fish oil in IBD is unfortunately inconclusive, and probably more research is needed. And you're probably going to hear me say that very frequently with a lot of these alternative and complementary therapies. Okay, so moving on to the next herbal or dietary supplement. So wormwood, or Artemisia absinthium, is a herbaceous plant that's prepared with a distillation of neutral alcohol and other herbs. Now, this plant has been used all over the world for different purposes, such as to help with fever and to help with as an antibiotic. And there has been, again, interest in seeing if this specific plant would be helpful in improving inflammation. So this has only been studied in Crohn's disease, have not found any data to say that it's been studied in ulcerative colitis. These were two small studies that were done in Crohn's disease, so the data quality is not high. And they did noted some clinical improvement and remission, and that's only clinical, but not, they did not study the effect on the active inflammation, whether it's through endoscopy or the markers or how the disease progresses. What concerns me a little bit is the risks regarding the use or the side effects were not reported in these trials. And then when you dig deeper and look into the same plant studied for other indications, one of the components of wormwood has been linked to nerve damage, seizures, and even psychosis. So definitely more research is needed regarding the use of wormwood, and the lack of safety data in IBD is a significant concern for this. The other thing you would hear about also is aloe vera. Can aloe vera be used to treat inflammatory bowel disease, and does it help? So I think the audience is familiar with aloe vera. It's a tropical plant, and it's in the gel form, it's known for its skin benefits. So it's been studied in one study in ulcerative colitis, where they gave a group of patients with ulcerative colitis oral aloe vera, so by mouth in a gel form, versus a sugar pill. And they did note that, yes, symptoms got a little better, but again, they looked at the endoscopic inflammation, or the objective measure of inflammation, and they didn't notice a difference. They did not report any risks associated with this therapy. And again, no data in Crohn's disease. And again, I'm sorry, you're gonna probably keep hearing this from me, is that additional studies are really needed to examine whether it has anti-inflammatory benefits. Now, I decided to include low-dose naltrexone because there's a big interest in this agent, and the prescribing practices that are a little different with the use of low-dose naltrexone. So let's first go into what is naltrexone. So naltrexone is an opioid mu receptor agonist. So basically, it counteracts the effects of opioids. So it's been traditionally used to treat dependence on opioids or alcohol dependence. Now, this opioid receptor that naltrexone acts on or binds to is also found in the gut nervous system. So the question is, when you give naltrexone and it acts on these receptors in the gut nervous system, can that potentially improve inflammation? So a very big review of all the studies that were done on low-dose naltrexone and Crohn's disease, and that's where it was studied, really concluded that the data quality is poor. There's no reports of adverse events on risks, and the benefit was mixed. So for that reason, at this point, we don't think that no-dose naltrexone is a replacement to conventional therapy, and definitely more studies are needed. So let's shift now from the herbal and dietary supplements to more of the gut bacteria-directed therapy, or the microbiome-directed therapy. I'm hopeful that we can kind of understand the difference between probiotics and prebiotics and go into what's called fecal microbiota transplantation. So what is the microbiome? When we use the word microbiome, we're referring to the communities of bacteria, viruses, and even fungi that make up the microbiome in humans. So it's dynamic. It's not, it changes, it has variations, and it's affected by many factors, including diet, medications, etc. It's very remarkable. The human microbiome has an estimated 100 trillion different microbes. Now, the healthy human gut has at least 1,000 different species of bacteria. So the microbiome has many, many functions, and these are just a few of the human microbiome functions. Number one, it does have a very important role in regulating the immune system. It also has an important role in synthesizing certain vitamins and proteins or amino acids. And then it also plays a role in breaking down toxic compounds. So how is the microbiome different in inflammatory bowel disease than in a non-inflammatory bowel disease? A lot of research has gone into analyzing the microbiome in inflammatory bowel disease. And what we've learned is that in inflammatory bowel disease, there's decreased diversity. And what that means, just as the word, we can relate to the word, is that there's decreased different types of microbiomes. And when there's less diversity, the function is not as adequate. So diversity is important when it comes to the microbiome. With that, there was also note that there is less beneficial bacteria. This beneficial bacteria usually helps maintain the health of the lining of the intestines. And then there is more bacteria that are what we call pro-inflammatory or result in inflammation. Now, what we've kind of struggled with is unclear if these changes that we see in the microbiome in inflammatory bowel disease, are they the result of inflammation, or could they have a role of being more of the cause of the inflammation? And we're learning more and more that it could be related more to the latter. So knowing that there is a change in the gut bacteria in inflammatory bowel disease, the thought is, can we change that bacteria? Can we make it back to being more healthy, and with that improve inflammation? And that's what drove the research into microbiome therapies. So one of the main or older microbiome therapies is prebiotics and probiotics. So the definition of prebiotics is a substance that's selectively utilized by the host microorganism, conferring health benefit. In simple, in simple words, I think this is just a substance that helps a specific type of gut bacteria grow further. So the way I explain it to to my patients, this is kind of the food, let's say, that the bacteria needs in your gut to grow further. So it's not digestible or absorbed. Probiotics, on the other hand, is defined as a live microorganism, which when administered in adequate amounts confers a health benefit on the host. So now instead of giving what's needed for your gut bacteria to grow, you're actually giving the microorganism, or you're giving the bacteria or living organism. Now, probiotics can be found in foods such as yogurt or in supplements. So let's look at probiotics and prebiotics in inflammatory bowel disease. Now, these have been studied extensively in Crohn's disease, ulcerative colitis, and pouchitis. So in Crohn's disease, the limited studies showed no benefit of using probiotics or prebiotics. In ulcerative colitis, the study showed mixed results. Some were positive and some were not. Now, in terms of positivity, we're referring to possible benefits in inducing and maintaining clinical remission, but with a specific strain. This was with a strain called VSL number 3. Now, this one is no longer available in the market, but it's now marketed as Visbiome is the other one that's available. Now, in addition, for patients with a J pouch, so J pouch is ulcerative colitis patients who've had a surgery to remove the colon and then have part of the small intestines made into a J, so a J pouch, there is a risk that this J pouch can become inflamed. And the research has shown that if we using this VSL number 3, which is currently marketed as Visbiome, it can potentially prevent recurrent pouchitis or recurrent inflammation of the pouch. So studying probiotics and prebiotics is challenging. As we've talked about earlier, there's many different strains of probiotics. It's challenging to realize what dose is needed. And for that reason, even according to our national societies, probiotics VSL number 3 or Visbiome can be probably considered to prevent this recurrence of pouchitis, but we really need better studies to identify what strains at what dose can be helpful in ulcerative colitis or Crohn's disease. So what about fecal microbiota transplantation? So this is a schematic that I'd like to walk you through about how fecal microbiota transplant happens. So first you get a healthy donor. A stool sample is obtained from a healthy donor. Now these donors are typically screened for autoimmune diseases and infectious diseases. And the sample is treated, and then the sample, the fecal sample, is transplanted into the patient with a specific infection that we'll talk about. And this can be done either through a colonoscopy, and then the sample is placed during the colonoscopy, or it could be done with enemas. And the hopes that is by transplanting a fecal sample from a healthy donor into the diseased colon, that we're able to restore the healthy gut bacteria. Now, fecal microbiota transplant has been studied extensively in a certain infection called C. difficile infection, or C. diff infection. This is an infection that can happen in the colon, and it can happen in patients who've needed to use antibiotics. And we know that in inflammatory bowel disease, patients are at higher risk of developing this C. diff infection. Now, fecal microbiota transplant has been shown to be very effective in preventing, in treating this infection, the C. diff infection, and it's been shown to be relatively safe. Now, what about fecal microbiota transplant specifically for Crohn's disease and ulcerative colitis? So for Crohn's disease, we still don't have the results of the studies yet, but in ulcerative colitis, we've had multiple randomized controlled trials. So these are high quality trials that used fecal microbiota transplant to see if it helps the ulcerative colitis, see if it helps the symptoms, see if it helps the markers of inflammation and the endoscopic appearance or healing on endoscopy. Now, out of all the trials that were done, 3 of them were very positive, that it might provide a benefit in induction of remission. The risks that were noted is risk of infection. However, there's still many questions about fecal microbiota transplant that are in the process of being answered. Number 1, what is the best dose? Number 2, what is the best mode of delivery? Some of these studies delivered the fecal transplant through colonoscopy. Others delivered it in the form of enemas. And it's important to see which one is going to be the best way to deliver it. The other thing that we need to learn more about is what's the risk of IBD relapse. We know in some of these ulcerative colitis studies, a few patients had a flare or a relapse after the transplant. And then the other important aspect is, what is the long-term safety? A lot of these studies followed the patients for a short period of time and have not defined what is the long-term safety. So there is a very large interest, or huge interest, I would say, in microbiome therapies for ulcerative colitis. And at this point, though, fecal microbiota transplant for ulcerative colitis is considered experimental and should only be considered in 2 situations. It's really as part of a controlled clinical trial, and there's many of them ongoing now. Or the other reason that could this be offered is if you have ulcerative colitis or Crohn's and have that recurrent C. diff infection that we talked about, then the fecal microbiota transplant can be considered at this point. And that has been shown to be effective in treating the C. diff infection. Now, what is the future of microbiome therapy? Well, it's certainly very different and exciting. So this is just one of those recent studies highlighting the progress in fecal microbiome therapy. We just talked about having to deliver the fecal transplant through enema or through colonoscopy. Researchers now are looking at packaging the spores of the beneficial bacteria into a capsule and delivering them as a capsule. And this is a small study, very early phase study, that showed a significant benefit and ulcerative colitis with this capsule. So definitely more to come with microbiome-directed therapy. Now, shifting gears to mind and body therapies. So in this section, we'll talk about exercise and then different modalities that have been looked at in inflammatory bowel disease, such as acupuncture and moxibustion, yoga, meditation, hypnotherapy, which you just heard a little bit about from Dr. Kiefer, and cognitive behavioral therapy. So mind and body therapies, I think, are very, very important. You just heard a really fantastic talk by Dr. Kiefer, who's really a leader in this aspect of gut-brain connection. So we know that the brain and gut are intimately connected, and we call this what we call a bidirectional relationship. And it's not just how you feel when you have active inflammation. It's really a lot of different factors like the microbiome, signals, hormones that play an important role. And the bidirectional relationship refers to if you have active inflammation in the intestines, that does influence the brain in terms of a higher risk of depression, anxiety, etc. Now, it's also a vice versa or bidirectional relationship, meaning that stress, anxiety, and depression have also been linked to increased risk of flares or active inflammation. So this is why it's important to treat both the inflammation and also the mental health at the same time. So knowing that there is an important bidirectional brain and gut connection, mind and body therapies, can they help address that part? So let's talk about exercise. As the audience is well versed with this, exercise has many health benefits. It's been looked at specifically in inflammatory bowel disease, and it's been shown to improve the general well-being and quality of life. Now, there's a few small studies that showed moderate intensity exercise, in addition to conventional therapy, being associated with a lower risk of relapse or active inflammation later on of ulcerative colitis and Crohn's disease. So this seems that, as a complementary therapy, exercise would be beneficial. But in these studies, what they meant by moderate intensity exercise was either a brisk walk or a run 3 to 5 times a week. Now, before, obviously, would urge patients to discuss exercise specifically with your doctor, as recommendations can be different depending on overall health status. Obviously, this will be hard to do in an active severe flare, and that's why it's important to discuss with your doctor. So what about acupuncture and moxibustion? So the definition of acupuncture is placement of needles into specific points in the body to achieve the desired effect. And that was mainly or initially done to treat pain. This is a practice that it's been around for many, many, many years. Moxibustion, on the other hand, is the use of heat from burning material applied over certain areas of the skin. So there's a burning of an herbal material, moxa, and this can be applied indirectly over the skin or directly with a separator. Now, these practices have been done for many years to help chronic conditions, pain, and sometimes acupuncture and moxibustion are used in combination. These have been studied specifically in inflammatory bowel disease, and in addition to conventional therapy, they have some encouraging results in improving symptoms of inflammation. But there are multiple limitations of these studies, and none of them have been shown to improve the disease course, but they can certainly help symptoms in addition to conventional therapy. So other mind-body therapies, I wanted to touch briefly on meditation, mindfulness, and relaxation. So meditation is a practice that's aimed at achieving heightened level of concentration and consciousness. Mindfulness is a form of meditation, and it basically refers to being present in the moment. And then relaxation is reducing tension in the mind and body. An example of that is certain breathing exercises. Now, all meditation and mindfulness and relaxation techniques have been shown to improve quality of life in inflammatory bowel disease. Some also have shown to improve symptoms such as pain, in addition to conventional therapies. So other mind and body therapies with interest in inflammatory bowel disease is yoga and IBD, and that has been shown to improve quality of life and minimal improvement in symptoms, in addition to conventional therapy. And then Dr. Kiefer touched base on gut-directed hypnotherapy, which is very important, and it seemed to be an effective form of complementary and alternative medicine. So it involves deep relaxation, focused attention, and enhanced ability to follow suggestions. Now, there are limited studies in IBD, but as Dr. Kiefer shared with us earlier, there is improvement in quality of life and symptoms, and even potentially to lower rates of ulcerative colitis relapse. And then I'll briefly touch base on cognitive behavioral therapy. This is when you work with a therapist in a structured way to be aware and change negative or inaccurate behaviors and thought patterns. So this has been shown to improve symptoms and quality of life. But as with the other therapies that we discussed about, there's no evidence to show that it affects the disease course, but it certainly can help with the symptoms and quality of life. So I just went into a lot of details about the different types of complementary and alternative medicine. We talked about dietary and herbal supplements. We talked about microbiome therapies and the mind-gut therapies. And there's a lot of information. And it's also, if you go online, there's a lot of information about complementary and alternative medicine in inflammatory bowel disease. So it makes the decision of what to do with complementary and alternative medicine very challenging. So my hope is to provide you with a practical approach based on what we know and what we hopefully learn in the future about these therapies. And I separated them into healthy lifestyle and then what we should do about dietary and herbal supplements and probiotics. So let's start with a healthy lifestyle. We know smoking is very detrimental to inflammatory bowel disease, specifically for Crohn's disease. It's associated with more active inflammation, higher risk of surgery, and even recurrence of Crohn's disease after surgery. So quitting smoking or smoking cessation, I would put as the number one in terms of adopting a healthy lifestyle. Now, heavy alcohol use has been also associated with more flares of ulcerative colitis, so moderating the alcohol intake is also a step that can be taken to have a healthy lifestyle. Sleep is very important, and we know that, that sleep in inflammatory bowel disease is affected. And it could be affected for the obvious reason. When you have active inflammation, you're not going to be able to sleep through the night due to pain or having to have more frequent bowel movements in the middle of the night. But in the setting of remission and not having symptoms, adequate sleep is very important. And that can be done through sleep hygiene, which are certain things that we can do without taking medications to help improve the quality of sleep, such as, for example, being consistent in the time you go to bed and waking up, not exercising immediately before going to bed, not eating immediately before going to bed, and not having stimulation such as a TV in the bedroom or turned on in the bedroom. Now, stress management, we talked about the mind-body therapies. We have a lot of evidence now that tell us that stress can play a role in increasing the risk of flares. So we talked about different mind-body therapies, and there was a recurring theme with these mind-body therapies that they did seem to be effective in reducing symptoms and quality of life. So adding mind and body therapies. Regular exercise regimen after discussion with your doctor to figure out which exercise regimen is right for you, and a well-balanced diet. We didn't talk about diet during this talk. It is being addressed in another breakout session. But the key here with diet is to avoid restrictive diets. Restrictive diets can be detrimental. It can take away certain vitamins, elements, nutrients that is needed for the body to heal. It can certainly play a role in causing fatigue sometimes too. So that's the sort of the healthy lifestyle approaches and one can incorporate. What about dietary and herbal supplements and probiotics? The number one, I think, step with these is always communicate with your doctor. Talk to your healthcare team about this. As a healthcare provider, I really welcome hearing more about what patients have read about or are considering using. We can help provide guidance on what we know if these medicines are safe or effective. The other thing that you should keep in mind when considering a dietary or herbal supplement is it safe? And safety is key. Safety is important, and it's the utmost of importance because some of these that have been marketed as natural have unfortunately caused, for example, liver or kidney injury. The other point that should be taken into mind is if I do take this dietary or probiotic supplement, does it interact with other medications? And that's where communication with your healthcare provider can help you with that. And then does it help? Has it been proven to work? And I shared with you some studies, and the key about these studies is not all studies or research are created equally. We have different qualities of studies, even what we consider as the best study, which is a randomized clinical trial. There's also different qualities, and that's what your healthcare provider can help you work through. So I want to end a little early so we can take any questions. So in summary, the data currently does not support use of any of the discussed therapy as an alternative to conventional therapy. Data regarding the use of dietary and herbal supplements is limited, but we know that multiple mind-body therapies have been shown to be helpful in improving quality of life as an adjunct therapy to conventional treatment. So thank you for your attention, and I'll see if we have any questions. Let me just switch through here. Okay, let me look at the chat box. The first question that I'm going to go through, it says, very encouraging to hear a medical professional speaking of these things. What works for one may not work for another. It's helpful to have this information to help decide where to focus. Thank you. So that's an important point, and that's, thanks for the comment. Because what we've learned that a lot of the times patients resort to complementary and alternative medicine is because another person has used it before. So it's based on a lot of what we call anecdotal evidence. So it's really our job as a medical community to provide the best information on, is this therapy effective? Is it safe? And, you know, just like with our conventional therapy, we try to hold these therapies to the same, if you want to say to the same bar, because we don't want to have these therapies cause more harm. So the next question is about, after my diagnosis many years ago, smoking was seen as health of UC. The new studies must have reversed this. So thanks for bringing that question. So with ulcerative, so we talked about how smoking is detrimental to Crohn's disease. We know that it increases risk of inflammation, surgeries, and also recurrence of Crohn's disease after surgery. Initially with ulcerative colitis, it was seen that patients who were smoking had less symptoms. However, more recent studies suggested that smoking did not really improve the outcome of ulcerative colitis. So knowing all the detrimental effects of smoking, if you do have ulcerative colitis, I still urge my patients to completely stop smoking because of all the detrimental effects. And to remember that although patients with ulcerative colitis who smoke might have less symptoms, the overall detrimental effects such as increased risk for cancer, different types of cancer, including lung cancer, outweigh any benefits. So we still recommend stopping smoking. Interestingly, this was looked at in the distant past, is whether nicotine can help ulcerative colitis, and they did some studies on nicotine, and those studies came back negative, meaning that nicotine did not help inflammation in ulcerative colitis. The next question I have is thoughts on glutamine, bovine colostrum, and bewelia. So the data on glutamine is also, we don't have much data of using glutamine in inflammatory bowel disease. I know it's been used for joint symptoms. Bovine colostrum, I think you're referring to some of these that are now marketed that could be as antibody therapies. Now, for the specific treatment of Crohn's disease and ulcerative colitis, these have not been shown to be beneficial. They can be used for other indications. Some of those have been used in irritable bowel syndrome with some benefit. Now, as the next question, this is a comment. Thank you. A great presentation. I have RA and have utilized many of these therapies with positive outcomes. Thank you for a great lecture. Here's a question. In terms of turmeric, does the form of it matters? Is there any studied recommended doses in pediatric cases? There seems to be a difference in response for Crohn's and colitis. Is that a result of receptors or purely location of inflammation? Oh, very thoughtful question. So in terms of dosing of turmeric that was used in the trials, so they used either 2 grams or 3 grams a day for ulcerative colitis. Those are the 2 trials that have shown some benefit of turmeric when added to sulfasalazine or mesalamine. The caveat with turmeric is what we call, it's a concept called bioavailability. If you take the dose, like I said, is all of that dose available to actually do a positive effect? It's for ulcerative colitis, it's an issue also, but it's more of an issue in Crohn's disease. And what has been recently developed is a formulation of turmeric that is what we call is bioavailable, meaning that is when you take in that turmeric, it's going to be available to actually do the positive effect. That part, this new formulation that I talked about, is being studied right now for Crohn's disease to see if it does have a positive effect. So the limitation of turmeric that we have to get around is that it's not easy for us to see if it's bioavailable, meaning that you might take a dose of 3 grams, but really what's available to your body is half of that. And that's where the research now is going into about finding a formulation that is more predictable on how much of the actual active compound your body is going to react to. So have you personally seen patients helped or maybe hurt by any of these options you discussed? So yes, I have seen patients who did benefit and tolerated well the use, for example, of turmeric or curcumin in addition to their mesalamine. I've also heard positive results from patients who utilize some of the mind-body therapies that we talked about in addition to their conventional therapies. So they would be on a medication to help treat their Crohn's or ulcerative colitis, but they would have taken up yoga or meditation, and they did notice an improvement. I have unfortunately seen patients being hurt by some of the complementary and alternative medicine, or what's called, I would actually rephrase this to what is marketed as complementary and alternative medicine. So some of the, an example of that may be basically stopping conventional therapy to take complementary and alternative options, and I've seen patients get worse when that happens. And then also have seen certain things that we didn't talk about in this presentation, but were marketed online as a complementary and alternative option for Crohn's disease, and the patient had some liver injury because of that. So that's the key of safety being the utmost importance. And there's a tremendous amount of misinformation online, and it's even as providers trying to sort through, it's very challenging. So that's why the Crohn's and Colitis Foundation has made this big effort to provide patients with the most up-to-date and accurate information on complementary and alternative therapies. And I'm sure Arushi afterwards can help maybe provide that link to the Crohn's and Colitis Foundation complementary and alternative therapy page. I think is really great. The next question is there a differentiation between different kinds of fish oil in these studies? Krill, etc., versus others. So the formulations that were used, there was differences. Remember that there was 6 trials in ulcerative colitis and 3 in Crohn's disease. The 3 in Crohn's disease were all consistent. They're called the EPIC 1 and EPIC 2 trials, and they use the same formulation. So it seems that for Crohn's disease, it was really very well done randomized trials. So the data does not support the use despite really good clinical trial. So I have here another question on melatonin. So just a comment on melatonin, apparently it induces H1 lymphocytes and worsens the clinical course of ulcerative colitis in Crohn's disease. Sorry, Th1, yes. I will have to look into this comment further. We have used melatonin in patients who need it for sleep, but I'll have to look into that comment further, and then probably see if we can get back to you on about that. And then the next question I have is on a specific probiotic, Saccharomyces boulardii probiotic. Is it anything you're familiar with the use of IBD? Yes. So Saccharomyces is a type of probiotic, and when we talked about the different types of probiotics that were used in inflammatory bowel disease, the one that showed a signal for maybe some benefit in 2 scenarios. One is preventing the pouchitis from happening again, so preventing recurrent pouchitis. And the other one is possibly benefit in ulcerative colitis. Now, the strains that were noted in that is in that VSL3. So the VSL3 contains 3 different species of probiotics and 8 different strains. So the names of the 3 species are Bifidobacteria, Lactobacillus, and Streptococcus. So that's what's in the VSL number 3, and that's the one that showed potential benefit for recurrent pouchitis, and possibly benefit in ulcerative colitis, although I would say the data there it's not very great. And actually our American Gastroenterology Association, which is our big GI association that reviewed all of this literature, suggested that maybe not to use probiotics for Crohn's disease and ulcerative colitis until we get more data on which ones are helpful. Saccharomyces has also been studied, and it's also been shown to have mixed benefit. But the VSL number 3, or the Visbiome right now, is the one that's been shown to have some benefit. And then for probiotics, I think a good source of information. So we talked about the Crohn's and Colitis Foundation website on complementary and alternative medicine. The American Gastroenterology Association, or the AGA, has a specific probiotic page on probiotics that are designed to provide information for patients. So it kind of walks you through: are you considering a probiotic? What are you considering use for? These are the different formulations, and these are the ones to be aware of. I'll see if Arushi can provide. I'll provide those links for Arushi and see if she can share it with the audience afterwards. Okay, let me go through the chat box, make sure I didn't miss any questions. So any further questions that anybody has, and it's okay if you want to ask, in the chat box, or if you want to just shout out your question. Okay, sounds good. So thank you all for being here this morning. It's really a pleasure to be with you. Thank you for listening in and for your questions.